is Dr. Marwa Rahimi, who will enlighten us about alpha emitters.
Thank you, Luke, for that kind introduction. My name is Marwa Rahimi. I'm a radiopharmaceutical scientist at Peter MacCallum Cancer Center. And we're going to ignore this title. I'm talking to you guys about PSMA targeted alpha therapies from a preclinical perspective. So Mo has really set the stage beautifully for this talk because he's provided a lot of the background, but I want to go specifically into developing PSMA alpha therapeutics, some of the challenges that occur with it, and also some of the opportunities that we have. Mo said very rightly that theranostics are a very complicated thing, but at its most fundamental level, these are basically devices that carry radioactivity to an extracellular target. For the purpose of this talk today, that target is PSMA. I don't really have to convince anyone in this room of why PSMA is such an ideal target. Its expression is correlated with disease progression, but from a structural biology perspective, the extracellular domain of PSMA accounts for 95% of its total structure. This makes incredible ease of access for radiopharmaceuticals ligands to bind to that surface, and once bound, they are internalized into the intracellular environment where the ligands can then deliver their radioactive payload. So these PSMA ligands have been in development since 1997. Starting first from antibodies, they quickly transitioned over to small molecules, and then between 2009 to 2017, it was a race to the finish. There were many ligands in development all at the same time, all in clinical trials concurrently, and it finally culminated in 2022 with the first FDA-approved radiotherapeutic for the treatment of prostate cancer, with the winner, PSMA 617, I guess, which was radio-labeled with lutetium-177. So lutetium-177 is a beta-emitting radionuclide. It is the most commonly used radionuclide for targeted PSMA therapy. But unfortunately, 30% of MCRPC patients don't respond to lutetium PSMA therapy. This is obviously, I'm sure you can appreciate, a significant segment of the patient population, and so there is a desperate need for alternative modes of therapy. Thankfully, we have some preclinical and early clinical data that suggests that alpha-emitting radionuclides may be the answer to this problem. So alpha-emitting radionuclides, they have unparalleled cytotoxicity. To put this in the context of beta emitters like lutetium-177, they have a range of about 1/10 of beta emitters, but within that smaller range, they can deliver up to 100-fold more radioactivity. So they are very lethal, very cytotoxic. They cause irreparable double-stranded DNA breaks in the cell, which then leads to cell death. When developing, or in the process of developing PSMA alpha therapeutics, we need to consider both the targeting ligand, the chelator, which is coupled to the targeting ligand, as well as the choice of the radionuclide. It's not just about doing structural modifications on the targeting ligand and not touching anything else. All of these need to work in a concerted effort. So in this discussion today, I'm going to be looking at some of the structural modifications, some strategies that we can do in developing, in optimizing these ligands, as well as why we select some of the chelators that we select, and also some of the radionuclides. But I'll be putting this in the context of PSMA 617 and INT because we have a lot of information about these therapeutics already. We know how they behave, and I'll provide a little case study for each one of these modifications. So starting first with the binding motif, this is easily the best way to improve the affinity of these compounds. So in both PSMA 617 and INT, they share the same binding motif. It is a, let's see if I can use the laser pointing here. So it's that lysine, urea, glutamic acid residues, but we just need the urea and glutamic acid to bind to PSMA. That lysine over here, that can be substituted for any number of other things, and that can then modulate the affinity. So this was seen primarily in the case of the development of MIP-1072 a few years ago, where one of its predecessors that was also being screened at the time had a cysteine at that residue instead of that lysine. And when they were both assessed head-to-head in preclinical in vitro settings, they saw that just the addition of that lysine at that position improved the affinity of this compound 5-fold to PSMA. This also reflected in the uptake in mouse models, where we saw a more prolonged and sustained uptake of this ligand. So the key takeaway from this is sometimes it just takes that one modification, just a lysine where a cysteine was before, that makes all the difference between a ligand that is translated into the clinic and one that's not. So the chelating moiety is also interchangeable in these instances and can have a significant impact on the pharmacokinetics. Outside of the core function of these chelators to capture the radiometal and maintain a stable complex, there's ample evidence that these chelators have a lot of they facilitate a lot of the internalization of these ligands. So this was looked at a few years ago by a group out of Germany, over here, where they screened DOTA against a panel of other chelators, all had a PSMA binding motif coupled to them, and they saw that of all of them, this CHX DTPA was 5 times better than DOTA at aiding the internalization of these ligands. So clearly the chelators have an impact, but unfortunately this CHX DTPA, it's great for internalization, but it's not very stable when complex to larger radiometals like alpha emitters, like the lead-212, actinium-225. And so other chelators need to be developed, and thankfully they are currently in development at the moment. These are some of the chelators for actinium-225 that are currently under investigation, and more are underway. And finally, the last kind of structural modification I want to talk about is the inclusion of other moieties like this albumin-binding moiety called S-ibuprofen that, when coupled to the PSMA 617, can allow for these ligands to increase their circulation time in vivo. There was a study from Mueller, the Mueller group a few years ago, which did a head-to-head comparison of PSMA 617 and its analog, which is exactly the same structure, but just with that albumin-binding moiety coupled to it. And they were both radiolabeled with actinium-225. And clearly highlighted in the blue here, it's called S-ibu-DAB. This compound was outperformed PSMA 617 in suppressing the tumor growth, and this was also reflected in the survival curves. So this was a great result, but I am a little bit hesitant to say whether this will translate into the clinic because just the year before that, they had another PSMA ligand with it was called ALB56. It also had an albumin-binding moiety, but when they radiolabeled it to lutetium-177 and investigated it in the clinic, they saw that yes, they were able to see a 2.3-fold higher presence of that radioligand in the tumor lesions, but that also corresponded to an increased renal uptake, which is obviously unfavorable, and we want to prevent that. So a lot of strategies that we can implement in optimization of these structures, but there is trade-offs, there are compromises that need to be made. So alpha therapeutics for PSMA, there are many, many opportunities, but also challenges. One of the main challenges coming out of the early stages of clinical trials that we're seeing at the moment are patients, 10 to 25% of patients, in fact, are reporting severe xerostomia, as well as kidney function deterioration. From a preclinical perspective, there are still many, many gaps in the research. This is an early field, this is expected, but we need to make a concerted effort into filling these gaps so we have more information going forward as well. Some of the discrepancies, unfortunately, are inconsistent mouse models used. We have cell lines with variable PSMA levels, and so we need to not standardize, but at least look at, maybe standardize is actually the best word to use in this case. I also want to impress the importance of involving radiochemists and chemists in this development, because we require the expertise to continue optimizing the radiolabeling procedures in developing new chelators to form these really stable complexes, the radioisotopes, because at the end of the day, their stability is what improves, what is a result of the success in the clinic as well. The availability of radionuclides is another hurdle that we've seen in developing these alpha therapeutics. Unfortunately, with actinium-225, there is only about 1,000 therapies per year that is available, and so we need to focus more on radionuclides like lead-212, which can be scaled for large-scale production as well as transport and supply. And we have companies like AdvancedCell who are spearheading this effort and they're building generators to allow ease of access for institutions like Peter Mac to have access to these radionuclides quite readily. The dosimetry, I won't go against, oh no. I won't go into it too much because Price Jackson gave a really great summary of this yesterday. But this gets even more complicated when dealing with alpha emitters because they have anywhere between 3 to 8 daughters in their decay process, and you have to account for all of their radioactivity in the dosimetry. And finally, their safety and handling, a very, very important challenge that needs to be addressed as well. Michael Gillen gave a great talk about what happens when you bring in a new isotope, particularly an alpha-emitting radioisotope, into a space like Peter MacCallum. You have licensing issues, you have new GMP-compliant procedures, and you need to retrain a lot of the staff, everyone from the radiochemists and the chemists who first handle the radionuclides to the biologists who evaluate them, all the way to the technicians who would potentially treat the patients. So clearly this is a multidisciplinary problem, but these are not insurmountable, in my opinion, and they just require multidisciplinary solutions. So right before I go, I know this has been said a few times to go beyond PSMA, but I think this quote by Dr. Evanyu really summarizes well what we need to do moving forward. We need to facilitate the development of the next wave of targeted alpha therapy that hones in on new targets while carefully engineering unique targeting moieties and testing various alpha emitters for tumor cell death. There is a world beyond PSMA. There are other targets that exist out there, and I think from a chemistry perspective, that is my training, I think there is only so much we can fine-tune these PSA molecules before we kind of run out of modifications and we have to look at something else. So, slightly controversial, but maybe we can have a discussion about this in the panel session. And finally, thank you so much for listening.